Good morning, student. Today we are going to learn about the removal appliances. So, removal orthodontic appliances are those appliances that can be inserted and removed from the oral cavity by either patient at will or by orthodontist for an adjustment. Basically, they are the appliances which can be self removed by patient himself or herself. The first removal appliance was kind of a chin cap, which was first used by Frederick Nessel in 1836. And this is the diagram which is showing, and it was used for the correction of class 3 malocclusion. The first typical removal appliance plate was used by Frederick Christopher Kinsel and John Stone in 1845. It was made of vulcanite at that time. Kingsley was the first one to use a removal appliance for correction of class 2 malocclusion, and his appliances was called as War Beater Guel, and it is used for jumping the bite for correction of class 2 malocclusion. So first come the removal appliance in the form of chin appliance, which is used for correction of class 3. Then comes some typical plates. Then comes a functional appliance, removal appliances given by Kingsley. Now, in year 1871, C.R. Coffin, who was a student of Kingsley, reported a new design for expansion appliance, which still bears his name and called as Coffin appliance after the C.R. Coffin. Henry Baker now used maxillary and mandibular vulcanite removal retainers with labial wires, but the vulcanite was not adapted to teeth. Instead, teeth were prevented from moving lingually by metallic spurs embedded in the vulcanite. This is the diagram which is showing the metallic spurs. The vulcanite is not in exact contact with teeth, but the metal spurs were in contact with teeth to prevent the relapse. And here it is compared with the normal Holles of today's normal Holles appliance, in which the acrylic is opposing just opposing the lingual surface of teeth. Okay. In United States, Victor Hugo Jensen was the chief proponent of the removal appliance. There was a divide um, of Pacific Ocean between Europe and US. In US, so because of Engel's of effort, they are more there were more emphasis on fixed appliances, but in Europe they they are more emphasizing of removal appliances. The benefit of this approach was that both removal and fixed appliances grow side by side. Now, removal appliances are differentiated in two forms: activators or functional appliances and active plates. At present, removal appliances have three major uses. First is growth modification, which is done by activator or functional appliances. Second is limited tipping of tooth movement, the malocclusion, which requires limited tooth treatment goal with limited tipping of tooths. And third is the most important one is retention. Advantage Advantage of removal appliances are the major advantage is that it can be removed by patient and himself or herself, especially when there is a socially sensitive occasion. Also, because they can be removed, patient can maintain good oral hygiene The appliance can also be kept clean so that the hygiene maintenance is better with removable appliances. Majority of the malocclusion, which requires tipping movement of single or multiple teeth, can be corrected. Also, you can also incorporate bite planes so that you can correct some degree of skeletal malocclusion with it also. Now, because removable appliance use mainly laboratory time and less chair time, you can treat greater number of cases with ease and with less number of clinical time or chairside time. Or also simple malocclusion can also be treated by a general practitioner rather than orthodontist. This also, since the premium time of an specialist orthodontist is not used, they come as relatively inexpensive. Also, the damage appliance can apply our undesirable forces can be removed by the patient himself or herself. Now, coming to major disadvantages, patient cooperation is very important for the success of treatment, as the appliance can be removed. Therefore, onus of placing the appliance inside the oral cavities on the patient, and for that, cooperation is mandatory. Also, it is capable of only tipping movement, lower removal appliances because of the presence of tongue and movement of lower sulcus, functional movement of lower sulcus because of the movement of tongue. The lower appliances especially is not tolerated by many patients. Multiple rotation, even a single rotation of high degree is difficult to treat. In extraction cases, it is, it is difficult to close the residual space because the body generally requires some degree of bodily movement or root correction or rotation correction. Therefore, it is uh, not possible to treat extraction cases with removal appliances. Greater chances of appliance being misplaced or damaged because the patient has to remove appliances several times, and therefore chances of misplacing or getting them damaged by a patient is more. Now, coming to case selection, what is the ideal case for removal appliance? The first and most important point is the patient must be cooperative so that he or she will be diligently placing the appliance in oral cavity and also maintaining a good oral hygiene. Therefore, internally motivated, cooperative, positive patient is required for treating a patient with a removal appliance. Occlusion. Severe malocclusions, which are severe in nature by either it is due to class 2 relationship or class 3 relationship, mainly due to skeletal nature, then it is not indicated to be treated by severe malocclusion, whether it is class 2 or class 3, it is not indicated to treat by a removal appliance. Do not try to treat removal appliance where there is a vertical discrepancy which is severe. There is extensive treatment required in lower arch when for correction of malocclusion teeth is required to be moved bodily. When there are extensive rotation in a single teeth or a multiple rotation case where soft tissue pattern is unfavorable, in all these cases, you should try to avoid removal appliances. These cases are better treated with fixed appliances. Now coming to classification, removal appliances are broadly classified into intraoral, extraoral, or combination of both. Intraoral appliances can be further classified in simple appliances such as oral screen or inclined plane, or unimaxillary plate appliance, or bimaxillary appliances. depending upon whether you are treating in only in one arch or in both arch, on the basis whether there is some active component of appliances present, the class they can be classified either as an active plate or retention plate. Some appliances are bimaxillary appliances by nature. Some are extraoral appliances which are removable can be chin cap and headgear, or it can be combination maxillary appliances with face mask for maxillary protection. Now coming to the major part of removal appliance, that is active plate. The removal appliances used at present were developed before World War II. At the time, there were two distinct different devices. First is active plates, which uh, which uses active force for correction of teeth, and the activators and functional appliances which use muscular forces or functional stresses to uh, correct the malocclusion. The different appliances, historical important appliances, which we have discussed early also. The first is the coffin appliance given by Walter Coffin, J.R. Coffin. Normal Kinsley in 1880s gives the jumping of the bite. Pierre Robbins constructed the first split plate appliance in England, 1911, described a J.H. Badcock described as expansion appliance, expansion appliance. Now coming to basic component of active plates. First are the active elements. What are the active elements? The different active elements that can be parts of a removal appliance are label bows, springs, screws, and elastics. Now, for retentive for retentive components, there are clasp, then there is base plates and Holly's appliance. Now coming to important part of active component of appliances, labial bows. So, what are different type of labial bow? A labial bow can have an incisor segment, a vertical loop, crossover section, and a retentive arm. These are the this is the diagram. You can have a labial segment on incisors, a vertical loop, and then on palatal side you have a retention arm. Now incisor segment usually in the junction of middle third to incisor third, right angle bend at distal third of lateral incisors or mesial third of canine, contact only the most prominent tooth. Now, your labial bow should not follow the malocclusion. Rather, your labial bow should follow a smooth curvature and it should touch only the most prominent tooth in a malocclusion case. Vertical loops, they are consist of parallel vertical leg joined by a smooth curve. It usually 9 to 10, 12 mm in length, extending 2 to 3 millimeter above the gingival margin. When these wires are crossing gingival margin, it should cross at a right angle. At gingival level, the loop is 1 to 1.5 mm away from the mucosa. You can appreciate here, it should be 1 to 1.5 mm away from the mucosa, not less than it, not less than 1 to 1.5 mm. Otherwise, it will touch labial mucosa or attached gingiva, and it will cause irritation. If you are trying to put it more than 1.5 mm away, then it will hurt buccal mucosa. So you have to keep this word at gingival level 1 to 1.5 mm away, not less, not more. The uses are the labial bows are used to move teeth lingually. They also provide restraining action on lip, supported for shoulder springs, bars, loop, and for hooks to attach elastic bands. Friction of labial wire against the anterior tooth act like a clasp. and can enhance a retention of an appliance. Now coming to the various types of labial bow. The various types of labial bow are short labial bow, long labial bow, split labial bow, reverse labial bow, robot retractor, Mills retractor, high labial bow with apron spring, and fitted labial bow. These are the various important modifications of labial bow. Now, what is a short labial bow? A short labial bow is constructed from canine to canine, and it is constructed using a 0.7 mm stainless steel wire. Uh, Retentive arms goes distal to canine. Indications are for minor overjet reduction, anterior space closure, retention. And also it is used for retention. Activation is done by compressing the U loop by 1 mm. And then a long labial bow, it has also a similar indication, minor anterior space closure, anterior to first premolar, minor overjet reduction, closure, especially the closure of, it is indicated especially for the closure of space distal to canine, guidance of canine during retraction and retention purpose. These are the indication of long labial bow. Now coming to split labial bow, as the name suggests, it is basically labial bow made up of two segments which splits in middle. Sometimes the labial bow overlap to each other and sometimes they end to end. So both type of them is called as split labial bow. Their indication is for anterior retraction and especially for the closure of midline diastema. And activation is done by, again, compressing the U loop by 1 to 2 mm. It is first given by Baz and Robinson, split labial bow. This is a clinical example of the use of split labial bow. Now, a reverse labial bow is the similar labial bow when the length extension of labial bow is from canine to canine, but the free end or retentive arm of the uh, labial bows, rather than going distal to canine, again goes mesial to canine or mesial to premolar in long labial bow case. Because the direction of loop is reverse for uh, uh, for uh, loop closure. Therefore, it is called as reverse labial bow. And free end of the U loop is adopted occlusally between either first premolar and canine in case of a long labial bow or canine and lateral incisors in case of short labial bow. The major indication is that when you have uh, previous space present distal to first premolar or dis, distal to canine, you cannot have a wire passing through same area, otherwise it will cause wedging action and opening of space. To prevent this opening of space, reverse label bow is indicated. So reverse label bow is indicated whenever you have spaces present distal to your last tooth and ending of your loop. If space is present and your wire is going through that space, that will cause opening of space. Therefore, rather than doing this, you could use this label bow. Now coming to high label bow with apron spring. It consists of a heavy wire label bow 0.9 mm to 1 mm that extend into buccal vestibule. Apron spring is made from high label bow with apron springs consist of a heavy wire labial bow which is made of zero point 0.9 or 1 mm that extend into the buccal vestibule. Apron spring is made from zero point 0.4 mm wire attached to it. Then the uses are retraction of one or more teeth, especially in cases of large overjet. Due to increased flexibility, you can use it in cases of large overjet, which can be said more than 4 mm can be said as large overjet. Also, the periodontally compromised teeth, which require very light forces, you can use this kind of high level bow with apron spring. These are the diagram. Apron spring is now activated by bending it toward teeth. Around 3 mm of activation can be built. The disadvantage of this is not disadvantage is that it is difficult to construct, and there is risk of soft tissue injuries, and also it is uncomfortable for a patient to wear this kind of appliances. Now coming to the next modification of label bow, it is called as fitted label bow. As the name suggests, the labial segment of the wire is rather than being straight, it follows the contour of tooth in mesodistal contour of the tooth, so that it fits properly on the labial side of tooth, and it is adapted to confirm the contour of the labial surface. The use of this is especially for the retention appliances, and especially in the case they, when there is previous rotation presents to avoid the relapse in the of the rotation. This fitted type of label bow is used. Now, one more modification is robot retractor. The idea is that you have to use a flexible bow made up of 0.5 mm diameter wire, and because it is flexible, you have to provide some kind of support to stabilize it within the mouth. So the stabilizations come from the hollow stainless steel tubes, which is used to prevent the distortion of this 0.5 mm stainless steel wire, and this is called as robot retractors. Is indications is same as uh, high label bow with apparent spring. Whenever you have to correct the overjet of more than 4 mm and you want to use light forces, especially in the cases when uh, patient age is high, or there is some kind of degree of bone resorption, periodontal problem, due to periodontal problem, then you can use this robot retractor. Uh, the basic construction is that uh, there is a loop at the high end of this spring, which is called as the robot retractor. Now, the similar appliance is called as Mills retractor, also called as extended labial bow. Extensive looping is used to increase the length of wire, thereby increasing the flexibility. It is indicated in patients with large overjet. Disadvantage are difficulty in construction, poor patient acceptability, and discomfort to the patient during the wearing of appliance. Now, label bow can also be modified in a several way. Uh, uh, this is a modification where a M loop is used to uh, palatally position the canine. Also, the label bow can also be used in a semi flexible manner to correct the rotation of teeth. as seen in this appliance. Also, it can be used to depress the neck of canines to correct the neck position of tooth. The appliance can also be label book can also be modified to form a hook so that the elastics can be engaged with appliances. Also, label bows can be dented to uh, to better correct the rotation to form a single point contact, and other point contact is made by a uh, cranked spring so that rotation can be corrected. Now the classification part of springs will cover in the next lecture. Thanks.